Hi, everybody. Welcome to Dr. Kogan and George Washington Center for Integrative Medicine podcast or YouTube Zoomcast. I'm Dr. Kogan, Medical Director, Associate Professor of Medicine at George Washington University in Division of Geriatrics and Palliative Care. So this is a part one of two parts on neuropathic pain. And what I'm going to do in the first part, I'm going to go a little bit over what is neuropathic pain, discuss some I'm not going to talk about statistics, but I'm going to go into set of causes and who likely to get it. Then I'm going to go into a typical management, diagnosis and management through the standard of care. And then we're going to go into integrative understanding of drivers of neuropathic pain, why it's important. The second part of the first part will be a demonstrative case report, which we published not long ago, a couple of years ago, that shows you how we work out some of the drivers and then how to address them. And in the second part, I'm going to put it kind of all together. I'm going to show you a very comprehensive management strategy and kind of all the tools that were all the common tools that we use in the integrative medicine. So let's jump right in. So what is neuropathic pain and how is it contrasted to other types of pain? Well, first of all, it's thought to be a peripherally sourced pain. The pain can be centrally when you have a damage to a central nervous system of some sort, like maybe a post-stroke, for example, and then that's going to cause spasticity that can lead to the pain, or pain can be peripheral. So a very typical example of neuropathic pain is a chemotherapy toxicity from a whole host of chemotherapeutic agents, and then as a follow-up, quite often there is a damage to peripheral nerves and a chronic pain. Another really good example is what we call a post-shingles, post-zoster neuralgia or neuropathy, when the virus damages peripheral tissue, including nerves, and causes pain. It could be a very devastating condition. Unfortunately, it's quite common. And neuropathic pain evolve or basically distributed in a variety of different forms. So there is, of course, I mentioned two: post-chemotherapy or toxicity induced, post-viral, post-herpetic. There's also diabetic, which is probably one of the most common. And then there's an idiopathic, or simply saying we don't know why that happens. It's a very common condition. It affects a very high proportion of people who are middle age and older, not really well managed. And that's the main reason why I'm talking about it, why it's on my channel, is that quite often patients with neuropathic pain are managed suboptimally. Neuropathic pain often diagnosed by sending patient to a neurologist and doing a series of tests. One of the tests is something called EMG, which is a nerve conduction test, and that's a definitive test. The tissue diagnosis is rarely needed in this condition. Sometimes it's needed to clarify precise diagnosis for certain medical treatment steps, but it's really a minutia that I'm not going to go into. Most of the time, it's not essential. Typically, when somebody's diagnosed with peripheral neuropathy, most of the providers will assess a couple of blood tests, the thyroid tests, B vitamin, B12, for example, folate, and a few other things. Rarely it leads to anything. And as we will discuss in the second part, the functional assessment of peripheral neuropathy is a lot broader and a lot more detailed. And as you'll see in the first part, in a second, we're going to talk about drivers. You'll understand why what we do with peripheral neuropathy is way above and beyond what you would expect, say, in the primary care office or in neurology. So the management of peripheral neuropathy in a regular pathway is limited. It's limited to primarily medications and behavioral interventions. So cognitive behavioral therapy, counseling for chronic pain, physical therapy. And the medications there's several classes. The opioids do not work very well for this particular condition. One opioid that's not routinely used is a methadone, which is, you may have heard, as a drug that's sometimes used for chronic heroin or other opioid addiction, but it's actually can be used for treatment of chronic neuropathy. Yet it's really pretty potent, and we try to avoid it, of course. There's classes of drugs. Gabapentin is one of them, and another one, Lyrica or pregabalin, So those are the medications that are most commonly used. They do have efficacy. Unfortunately, 100% of them have side effects. So when you start on this medication at low dose, you may tolerate those side effects very easily. Side effects tend to be cognitive, kind of a blurry and kind of brain fog, and not being able to think fast and efficiently. The pills can, at the high dose, can actually be very toxic. They can cause sedation. They can cause delirium, which is the most fearful complication of the Neurontin, actually of all these medications. The second class antidepressants, particularly FDA approved, is duloxetine, which is a Cymbalta. A little safer, it's class, just not as effective. And I would say that at best, the efficacy is quite limited. In the second part, if we have time, if I decide to run the video a little longer, what I will do is I will discuss the kind of a way we think of how you grading and how you initiating and continuing treatment. So for example, why would I decide on Lyrica versus gabapentin versus some cannabinoids, and what is the decision process and what's the evidence for that? But in this first part, we're just going to go into drivers. And I think this is where, of course, integrative medicine tend to be the most significantly different from traditional allopathic model, is that we don't say that diagnosis is appropriately last step. It basically, what it means is that we always dig deeper. We say that the diagnosis is a superficial way of understanding problem, and you have to understand an underlying driver to be able to effectively address a condition that you're treating. In this case, we're talking about peripheral neuropathy. So what I'm going to do here, I'm going to share my screen, and I'm going to show you a case, and we're going to go through this in basically how the case came up, and I'm going to show you some of the key drivers based on this case. So we published this case with the help of some of our medical students, and also Jessica Probst. You already familiar with her. She has been on this channel probably more than once. Jessica is a physical therapist to whom we refer a lot of patients. So this is a particular case that speaks to two core drivers. The first core driver is mercury toxicity that was missed in this patient for more than 10 years. And then the second driver is a functional musculoskeletal lesion. Sometimes we would call it an osteopathic lesions. But in essence, it's basically a peripheral musculoskeletal problems that either compress the nervous tissue and then cause the pain, or they simply contributing to dysfunction of the muscular system and causing weaknesses, and pain is already there, but the muscle weakness basically leads to a poor function of one particular individual. So this is a case of 62-year-old woman. She presented to us struggling with a chronic pain for a decade plus. You can read here a variety of different sort of explanation how mercury toxicity can lead to the chronic pain. I'm not going to go in there. It's quite well established that mercury is probably the most dangerous neurotoxin in our immediate environment that we're all exposed to some degree, whether from seafood or if you're unlucky to have silver fillings in your mouth, that also contributes to the total toxic load of mercury. So as I mentioned, actually, I'm going to walk you through a little bit of an actual story of her case. So she was 62-year-old. She basically suffered from a number of problems, hypertension, insulin resistance, etc. But for over a decade, she had a progressively worsening neuropathic pain on the left lower extremity associated with fatigue. Now, of notice, it is not typically expected that the patient's going to have very symmetrical distribution of neuropathic pain. There's a lot of misconception that it's always glove and stock distribution, that the patients tend to not have the other parts of body affected. You know, the pain can be anywhere, and it doesn't always get distributed symmetrically. Sometimes one part is much more affected than the other, as in this case. And she basically had 10 years of different treatments through the insurance model, through a typical neurological approach. The moment she saw us, it was very obvious because she had a mouthful of silver fillings, and she was eating quite a lot of different seafood. So this is her initial level. As you can see, her total mercury on presentation was at 11.8. This is the number right here, which represents not just 95th percentile, but over 99th percentile. So it's a very, very high. And as you can see, in essence, she had primarily, well, she had both elevations. So she had 95, just above 95 percentile for the inorganic from amalgams, and, mostly 11.3 here, or 99th percentile or so of the organic mercury. In essence, basically all the levels were elevated. And so this was one of the treatments. So we've treated her to try to get rid of the mercury out of her system by sending her to biologic dentist. And in addition, she had a lot of different musculoskeletal dysfunction, and she was referred to Jessica Probst and her team, and she was also treated there with manual medicine. And this is kind of the timing of how it happened. As you can see, it takes quite a while. So initial treatments, while we were getting the workup together, took some months, and then the actual detoxification, as you can see from here, took about a year roughly. But the result was complete resolution of her pain and actually complete recovery from neuropathy. So in this case, patient will no longer ever need medications. Excuse me, spraying allergies. She will not need any medications, and she will not know what neuropathic pain is going forward, because the driver, the core driver in her case, was completely resolved. Now, this is a success story. By the way, I'm going to, of course, post as usual link to the study in the video description. And as you can see, the follow-up, we did follow up levels of her mercury. They were rapidly decreasing. So basically, this was the first follow-up. It was 70% total mercury reduction. It's still quite elevated, but often what we see is when you have the first 50, 70, 80% reduction, that's when most of the improvement medically occurring from the detoxification. But, we tend to aim at a lot lower numbers, and eventually we got there. It just took a while. So yeah, that's the case. Now, I'm not going to go here into discussion about detox of mercury. I think that's a whole, you can read it. And there's a lot written about it. She did have total of 7 visits to physical therapy. We actually, interestingly, I believe, no, it's in the other case. I'll show you. We did estimation of the cost, and basically compared to the standard approach, this saves thousands of dollars, because some of these tests are very inexpensive. They're direct to consumer. Like MRI basically is going to cost 10 times more expensive than some of these functional tests. And so we've evolved over the years an effective way of trying to reduce the cost to not just our patients, but to the society. And of course, the treatments also didn't evolve any specifically complex and expensive drugs. We rarely, if ever, nowadays utilize binders or strong chelators like DMPS or DMSA or EDTA, primarily because since the invent of liposomal binders and liposomal glutathione, the need for that is rare. I would say that most patients detox very efficiently with use of different products on the market. Yes, we like Quicksilver brand, but there are many others that are very good. Now, it's quite important to realize that the other long-term drivers of neuropathy I didn't fully discuss. So the diabetes is a big one. Diabetes is the one that often much harder to manage, because if you don't manage diabetes and patients still have elevated sugar and toxicity from advanced glycosylated end products, it's kind of hard to get that fixed in essence, because if the sugar toxicity is still there, you have to work on that first. That's a big one. If somebody had chemotherapy and it caused permanent damage, it's also not easy to treat. In this specific module, in this first part, I'm just going to mention cannabinoids, but I'm not going to actually talk about the evidence, but I will tell you a couple of things. we definitely seeing that CBD and CBDV and other cannabinoids, but CBD is probably most evidence, have some neuroprotective point or some neuroprotective effects. And over months to years, they tend to have a quite significant effect on chronic pain, on neuropathy pain. I often start cannabinoids topically because if they work, that's godsend because they locally impact tissues and you don't have to worry about overdose. It's also often quite cheaper. But systemic use is also very useful and important. Okay, so let's review. You have to look into drivers if it's not obvious what the cause is, like let's say diabetic neuropathy. Once you looked at the drivers, whatever you identify, you have to address. That's a first step. Going to drugs, going standard approach will never be effective, even close to what the case I just showed you. If you talk to neurologists, how many cured neuropathy cases you've seen, you're going to have a blank stare at you saying none, because it's never expected. So even one case of peripheral neuropathy being cured, like in that case, is very unusual. Yes, patients can be managed, so pain can be suppressed and they can be feeling okay and functioning, but it's not really a cure, right? It's just a Band-Aid. So with that, I think the first part, I'll stop here. Thanks so much for watching. For the second part, which I'll probably post either in a day or two, because I don't want to spread this parts. I'm sure some people would want to watch both parts. So if you do have a neuropathic pain you'd like us to help you out, of course, let us know. And of course, as usual, this is not a medical treatment suggestions. This is just purely for educational purposes. And similar, just like we publish case reports and peer review literature, similarly, this channel is just for educational purposes. Thank you so much for watching. I'll see you soon, following on what's new in integrative medicine world, how we manage conditions, interesting cases, and a variety of different updates. Have a wonderful rest of your day. Take care. Bye-bye.